malaria treatment, and I think this is some of the things that we were talking about diagnosis. So once we diagnose that, then we have treatment options available. So you can see these are the things that goes on in the mind of infectious disease consultant, or should go in your mind when you talk of malaria treatment, or when you're asked to answer a question for malaria treatment. So empiric basically means best guess. And there are a lot of things they keep in mind. For example, where patient contracted disease, because there are resistance patterns, especially in those particular areas, and you have to go to CDC website to find it out. And then again, you have to ask the patient if they have been taking any prophylaxis, in terms of, even mosquito net or some other tablets religiously. And then again, if there are any other contraindications for the drugs, especially if a person is pregnant, and then it depends upon which trimester we are talking about. And then again, presentation of the patient, if the patient has in the initial stages or have organ dysfunction and cerebral malaria and so on and so forth. So you can see from here the treatment lies on many factors that the physicians have to keep in mind. And I think this was where we left over here. So these are choices in terms of treatment. Some of them are oral, and some of them are, of course, IV. And you can imagine IV would be for extreme cases when we have cerebral malaria or when we have other contraindications for treatment for those particular patients. And if you look at the first line of treatment, for example, if it's uncomplicated and the person is presenting here for the first time, and chloroquine has been the drug of choice, but as you know, there is a resistance coming up, or we have alternatives as well in terms of people who either are chloroquine susceptible or resistant. So we go by that, and you can see these are the drugs that I would want you to be familiar with. And these drugs, some of the drugs are to be included in the exam, especially we talked of TB, we talked of some other drugs, when I literally tell you not the dosage per se, or not the whole therapy, but at least you should be aware of the names of the drugs and what are the options available. If it's a severe malaria, then of course, as I said earlier, you have to give IV treatment. First line of treatment is quinidine. And then again, I would not tell you right now, but I'm pretty sure when you went to physiology, they were talking about quinidine at the time when they were talking about heart rate, talking about the blockers. So many of the drugs which are there may have kind of a simultaneous or other effects as well. So keep that in mind when I said some of them are contraindicated and some of them have to go along the patient history. And then again, we are still struggling in terms of any resistant malaria. And then again, as I said, the drug of choice basically is chloroquine. And we would rather prefer to treat patient with chloroquine or hydroxychloroquine. But then again, if we suspect that Plasmodium vivax or ovale is involved, other than falciparum, we may want to add to primaquine to the regimen. And then again, the whole idea is we need to eradicate dormant hypnozoites. If you go to the circle, you will see that some of them are more nasty than the others, and we want to break the cycle. So that's ultimate goal in these cases. So the next disease we're going to talk about is giardiasis. Again, the causative organism in this case is Giardia lamblia. Is also, some of the names are like old names, but we still call them, and you will see in old technology, old school people, we used to call them intestinalis or duodenalis. The idea was you found that particular bug in that area. So instead of having two different, because duodenum is a part of intestine, right? So it was a little bit confusing for the people, especially when you talk of, for example, Helicobacter pylori. You would have thought that it's something to do with pylorus, but it's got to do with the whole stomach. But it's just the way it is that names have been usually are revised, updated, but in textbook you will find both. This basically is one of the commonest cause of diarrhea worldwide. So probably we'll have one of the workshops on systemic microbiology. Right now we are just doing individual microbes, and we are telling you this one causes pneumonia, this one causes diarrhea, this one causes such and such thing. But you would see a patient coming with diarrhea, and then you have to look at all the possible causes, whether it be bacteria, parasites, and viruses, and you want to differentiate one from another. But again, common cause of diarrheal syndromes worldwide, most frequently identified intestinal parasite in the US. So that's important. Those of us who are living here and want to deal with that. Children are commonly affected, and it goes without saying because children would need help from their attendants for proper sanitation and cleansing. And you can see from here fecal oral route, and the problem is they ingest cysts. Now, same thing for the life cycle, and again you can see. Let's see if I can enlarge that. So over here, well, you can pick up from anywhere. So let me see what's the best option for me to pick up from here. Okay, let's pick up from here. So you can see from here, let's say the person is infected. The person is infected. Again, the same legend goes over here. You have I as an infective stage. You have D as a diagnostic stage. So the trophozoites, that's normally a question, what is passed in the stool? What are you looking for in the stool of a person who has giardiasis and presenting with diarrhea? So basically you are looking for trophozoites. So they are passed in the stool, but the problem is that they don't survive in environment. So if I was to tell you that, what it means is many a time if you go to a physician, they say, you have to bring the fresh stool specimen. That's what they will tell you. So you cannot pass the stool last night and bring it next day to the lab because it would not pick up the cyst. Okay, and sometimes what happens is that the cysts are lining the intestine, right? So the proper handling of the specimen is important, right? There's some of the terms like mid-catch stream, fresh stool, things of that nature. They have a definitive reason why they're asking for that, okay? And again, you can see that they will pass it and they will deposit it on not only the places in the washrooms, but they can contaminate water, food, or hands and fomites with infective cysts, and then people. This is called a fecal oral route. This is how the transmission goes. We used to teach that, little kids, babies, they will put their fingers in their mouth. Well, that's something else for the newborn babies or infants. But normally this is the cycle for foodborne diseases or waterborne diseases or those diseases that basically are there. So you can see from here, this is how a cyst looks like. We ingest the cysts. Okay? And then again, the whole cycle goes, and you can see from here that they reside in intestine, and this like funny looking structures over here. Cyst, it changes to trophozoites, and the trophozoites can divide, and then the cycle goes on and on over. Okay, let's go back if I could. All right. So the presentation of giardiasis basically could be or chronic. Both of them present with diarrhea. Acute one will have cramps, pain, bloating, flatulence. These are very common gastrointestinal complaints. Right? If it goes untreated, And if you're living in an environment where you continuously ingest those cysts because of water contamination that happens in many places. So you may have chronic infection. So it's going to be alternating diarrhea with constipation. So this is alternate diarrhea with constipation. So they are totally opposite. The copious amount of stool they pass, light colored fatty stools, weight loss, it may mimic like lactose intolerance. The reason is because you need those enzymes lining the those small microvilli, but if they get damaged because of the cyst, then you may have a problem. And eventually, if it happens in the kids, that is also one of the causes for malnutrition. And have vitamin deficiencies because of chronicity of the problem that we normally see. How do you diagnose? The gold standard, as I just told you, you're looking for ova and parasites. They call it ONP. So if you see any stool tests, say looking for ONP, they mean is ova and parasite. And then again, you can see that you can miss the sample, you can miss the ova parasite because they are lining. And you have to make sure that you want to take multiple samples and look over and over again. But there are other methods also available, which is duodenal aspiration, biopsy, so you can do that. Or you can also resort to the fancy immunological tests, which are becoming norm these days. You just look at an antigen and antibody and want to be quick. But again, it's going to cost you money. ELISA, immunofluorescence are there. How do you treat it? Of course, you need to discuss with the healthcare provider. I just told you the reason being treatment is not enough if the source remains. If you have a bad habit of not washing your hands after washroom and so on and so forth, or you're consuming some contaminated water or food, then that needs to be taken care of. Otherwise, you can see that the goal of the treatment is you want to prevent morbidity, illness, and also prevent mortality. The drugs of choice we have are oral antibiotics, metronidazole, tinidazole, paromomycin, and nitrosuccinide. So these are some of the drugs. The classical drug is metronidazole or azole-like drugs. But the best kind of management, I would say, is you want to take care of your personal hygiene. Okay, now we jump from Giardia to amoeba, amoebiasis. You know, and ISIS shows you that it's like a disease condition from that amoeba. So causative organism in this case is Entamoeba histolytica. Entamoeba histolytica, there are quite a few cases worldwide, and the most important thing you have to keep in mind when we talk of Escherichia coli, I gave you there's strains of that, and they would causing clinical damage based upon the penetration of the layer that they have. Okay, so again, it's invasive, and you wonder, it looks like a very simple or benign, so to speak, organism, but it does cause death. And then again, it depends, you know, especially when the children are involved, when they are not treated well, when they are malnourished, when there are neonates involved, pregnant women, so on and so forth. We have 4% incidence in US, especially in the tropical area. Again, the transmission is fecal or oral route. So if you look again at the CDC cycle over here, so you can see over here, let me go to the same legend in infective and diagnostic. And I'm repeating over and over again, but remember, I'm going to ask you which one of is infective stage and which one is a diagnostic stage. Okay. Now, if you look at the cycle per se, you will see from here that we have a multiplication which is taking place from the trophocyte, which will either go towards the trophocytes or going to go to cysts. And then there are different levels of maturation of the cyst. So you have to look for all these cysts. They're all diagnostic. And diagnostic means they exit the host so they can be seen in samples of stool. That's what I'm trying to say, okay? And then if you look at the cycle again, another key added over here is that when we talk about amoebiasis, we talk of a non-invasive colonization. So this means, which I did not talk when I talk about giardia. So you may have a non-invasive colonization, meaning that they just love to stay by your intestine, don't really go and cause problem. Or they can cause problem within the intestine like diarrhea. Or they can pass the intestine and cause extra intestinal diseases. So this person is more severe than the one that we discussed earlier. Okay. Now, if you go back again, look at the cyst and trophocyte passed in the feces. You can see from here, and they are both infective, especially the cyst. And trophocytes per se are not infective, but are diagnostic. And then again, they will have to go and form mature cysts, which are, of course, both, there for causing disease or diagnostic and infective. You ingest them. But if you compare this picture over here as to the previous one, so you can very much tell that it can firstly have to go in intestine, local, and when it gets absorbed via blood, the blood is going to take it to liver. So you can see it may cause an abscess in the liver. We call amoebic abscess. It's going to cause abscess in the lung, amoebic abscess, and even it called abscesses in the brain. So that's serious issue in terms of entamoeba histolytica. So it has this potential being a waterborne or foodborne disease, be absorbed over there from your intestine, and especially you can see from here, and then go all the way and cause problem. It may look very simple to you, but the fact is it's not that simple. Just imagine you have an amoebic cyst in the brain. And I still recall, I remember when I was doing residency in the surgical ward, and we came with this young girl, and she had a abscess in her liver, right? But she was kind of resistant, so we had to explain to her, because the problem with abscess is that it can burst open. If it bursts open, so it's going to cause a very severe immunological reaction, like a shock-like condition. And then again, we wanted to remove it. But remember, liver is a very delicate issue, so it was very difficult. But as a rule, we wanted to make sure that the patient makes that choice. And it's really tough. So she took a while, I'd say maybe like a week or so, to make up her mind. And before they will operate on her, they also have to explain to her that, honestly, what may happen, we call that as a table death during the operation, that when the surgeon is operating, it can burst while we are, and it can go and spill out and cause death there and then. But that has to be explained in terms of that. And I mean, I was young at that time. I was a part of that. But unfortunately, what happened, it did burst while she was being operated, and she died. And I used to know it was better for her to live with this cyst. But the choices are tough. The choices are tough. And especially when you go to that ordeal, talking to the patient, especially in this kind of decision-making cases, is really very tough on you. It's very tough for the patient. But keep in mind that by all means, parasites are serious. They should not be taken lightly. And you wonder, how come such a big cyst get absorbed in the intestine and go and locate anywhere in the part of the body? But it does. Okay? So, what normally happens is that clinical presentation, again, you can see, because many of the problem with the parasites are that people don't present with the symptoms, because everybody assumes constipation and diarrhea are so common that if people were to come and report to the physician, they're going to report it every day. They always are, people are trying new foods, they're going through all these different things, and some of people may have different norms as well. But the most important thing, as I just told you, of this young girl that we operated upon having a liver abscess, ended up losing her life. But you can see that fever rate, whatever is telling over here, liver abscess means there is a mass in the liver. It could be cancerous, or it could be anything. But again, liver is very sensitive, and the only problem is that even a slight push, kind of a blunt injury can burst it open. So this is like a catch-22. It's difficult to make the decision. But if people do have intestinal disease, they will have abdominal discomfort, malaise, flatulence, bloody diarrhea with mucus. And I still remember first year medical school, we used to wonder when people used to come as a patient and say, there's a gas that comes in my stomach, say bloating, and it goes into my brain. And we used to laugh and say, how can a gas come from the stomach and go into the brain? All these kind of things. So flatulence is a big problem out there for most of the patients, bloating, belching, and this is for real. And then we found out later on, Helicobacter itself produces ammonia. So many a time you laugh at the patient's history and clinical because of your own ignorance. You are not aware, and that is true. So things are evolving. That's why we have in medicine continued medical education. You cannot do something, hey, I did it like 10 years ago, everything the same. No, things have changed, right? So the key is that the patients don't lie. As they say, the hips don't lie, but there are many other things that don't lie. But there's a good reason, okay? Anyway, so how do you diagnose amoeba, intestinal amoebiasis, gold standard again, O and P. So they are looking for the cyst or trophocytes of Entamoeba histolytica. Again, you can see we look for different samples, and we can take some of the Entamoeba histolytica, which may be benign, as so this has to be seen by a specialist. It's not easy. Okay, so you have to get trained for that. And then unfortunately, if you have liver abscess, I gave you an example, then we may have to do all this serology and liver scan. The reason being, we want to find out how much liver is damaged and what's the compromise over there. This is how it looks like in the stools. For treatment options, of course, it has to be supportive, because people may have malnutrition, people will have electrolyte imbalance, people have many things. You have to replace the electrolytes. That's number one. And then again, the goal is you want to eradicate parasite. And again, you can see that goal cannot be met if you were just to eradicate parasite from the patient and not from the contaminating source. So if, for example, you're traveling somewhere in a village in Africa or any far off place, and you found out the major body of water is contaminated with the cyst, and that's the only support those people have, then we are in trouble. Okay? And again, you can see we can do needle aspiration to find out, if needle aspirations are usually done for an organ without opening that organ. So but again, that's tricky, because while you're poking a needle, things can bust up. So the antibiotic therapy is available. And again, the options we have, because remember I told you the complication of disease, the extent of disease, and then again, whether it's only their intestine will determine as to what are we going to do. But you can see from here, the medicines are available. And we also talked about non-invasive colonization, where you happen to be asymptomatic yourself, but you are a cyst passer, or you have a mild intestinal disease. Again, those people who are in food industry or who are in their hotel and all these things, they should not be continuously having. So you can imagine if you were to enforce hand washing and all kind of stuff for those people who handle your food. So the other important thing is that if you want to give some drugs, we call luminal. So they are going to take care of these extra intestinal, so to speak, organisms in the intestine. But if you want to treat tissue problems, so your drug has to pass the tissues. So that's like a drug delivery thing that it has to be well absorbed. Again, metronidazole is there, available, and we give that to treat the tissue amoebiasis, and then it is added with a luminal agent. So luminal agent, you can see from here, that's what want to suggest that they're lining the intestine. And then again, the idea is that we don't want to let it progress to a very severe intestinal disease where you have increased load of this this organism, and you end up in liver abscess. Okay, but what do you think? Why would a thing which is intestinal in nature would end up causing liver abscess? Why? Why? Why would you think that we are worried about a particular intestinal disease ending up in causing problem in the liver? Yeah, because all absorption goes to the liver. Simple as that. There is a special circulation, portal circulation. So everything that's absorbed goes to the liver. Make sense? So anything which is intestinal, if the microorganism to be absorbed, they're going to go first to liver. So that's good or bad because liver is detoxifying agent. It's a vital organ. Okay, and sometimes you would avoid corticosteroids because if you give corticosteroids, there's something we call toxic megacolons. It's one of the disease. I think at this stage, if I was to ask you this question, which of the following agents cause toxic megacolon, and I list Giardia, I list amoeba, and so on and so forth, you know for sure that amoeba is the one, especially Amoeba histolytica, that's going to cause one of the clinical symptoms we call megacolon. So it kind of increases in size, but it's toxic. Okay, so if you remember the first slide, it is coming from there. We talked about three important things. We're going to talk now about another disease we call Chagas disease. Chagas, you can see from here, Chagas disease. Now, the causative agent is Trypanosoma cruzi, nothing to do with cruise. Cruzi, also commonly known as American trypanosomiasis. So trypanosomiasis is an important, especially in this part of the world, because if you have diarrhea, so you want to investigate that. And again, the problem with these kind of things is that if you are infected, right, and you are undetected, infection can be lifelong and life-threatening. And that happens very commonly in Latin America. And then because of the trafficking back and forth, people can carry it. It is transmitted via feces, and we have a triatomine bug. This is called a bug that considered, we call triatomine bug. You can see from here. I think it's very clear. And this also is known as kissing bug. So it's going to kiss you and give you the surprise. So the most important thing is this one category of diseases which we called neglected parasitic infections. Neglected parasitic infections, and sometimes they just try to put on the back burner, you know, and because there's no talk of it, and we tend to forget. So this disease, Chagas disease, was considered for that. Is important, and also the way we teach, for example, you know, I mean, I didn't teach about Zika virus last year, but I'm going to talk about Zika virus this year. So some of things are like trendy. Once they come up, we talked about Ebola virus when it came up. So it becomes very obvious, and you should be aware based upon the principles that some of the people, especially in this technological informative area, people have a lot of time to know more than you. So you are always going to be in a situation they're going to be challenged. Okay, so this is considered as neglected parasitic infection, Chagas disease. And again, as I said, that we just pick a few, I would say maximum 10 life cycle things that you need to spend a lot of time on that, because it will not be a single life cycle that you should not expect a question from there. Okay, because these life cycles are from CDC, very important. But what I'm trying to do and impress upon you is how to deal with that. For example, if I was to look at that, you pretty much know that there are two important things we have to find out: infective versus diagnostic. That's number one. Number two, we have to find out that between that causative agent and host is there's a vector in between. That's another thing you have to know and find out. For example, in this case, we talk of kissing bug. So this means a vector. So it's going to be a go between you and the microorganism. Number three, I want you to pay attention to the extent of morbidity or disease that these bugs cause. So you can see from here, looking at this picture, which CDC has very nicely turned in terms of the color formation, that from intestinal to the stomach and lungs and brain. So you can see the more colorful it is, the more problematic it's going to become. Okay. Fourth thing is, as I said, in the malaria, some of this life cycle is completed within you, within the host, and some of the life cycle is considered out of you, so extra host thing. So sometimes, especially for malaria, for example, in this case, if it is going to come, let's say over here, it has to go through these phases within that bug, right? So that goes within the bug. Because remember, there are many things that we talk of, especially to get rid of those bugs, like get rid of those mosquitoes or any other arthropods, and put something in the air, for example, spray or drugs. So like bed bugs, for example, so they are there in the atmosphere, and it eliminates that particular microorganism from the bodies of those bugs over here, because you can see from here that this one over here is infected. So whatever is excreted is picked up by this bug and then goes out into by, it's not a fecal oral route, but you can see it's just like a bug which is going to kind of, inject into you. So bugs basically have this ability to inject. So they kind of as bad as needle stick injuries. Okay. And then again, some of them over here, for example, are human stages. So it goes like human cycle, bug cycle, and then, both of them are taking place at different levels, and we have to deal with them at all. So FDA, for example, will come and want to find out water reservoirs or food or anything of that nature to make sure that that doesn't take place, or they're going to go and find out that if that particular vector is eliminated, for example, in like West Nile virus, so want to eliminate that particular mosquito that carries it. So that's a part of public health. So that adds another angle to it, but it's very important. Okay, so what I'm trying to impress upon you is that when you look at these kind of life cycle, you kind of understand and spend some time on that, and it will help you to understand the clinical picture. It will help you to understand the nature of medicine that we use. It also make you understand the way we treat these kind of problems. Okay. And again, for example, if you look over here, part of it which is there in human, for example, you can see some of it is going to go and attach, just like bacterial pathogenesis. And at the same time, I was about to say that I would encourage you or expect you to read parasite immunology as well. How would immune response respond to a parasite? Because parasite immunology is a unique thing, right? And then again, how antigen is handled, and all these kind of things that are there. If you remember, one of the things I taught you at that time was the parasite have this ability to not present the proper antigen that will evoke immune response. So they have one capability to fool your system around by continuously changing the antigen. So these are some of the things you have to keep in mind. And that's why we teach immunology first and teach rest of the stuff afterwards. The expectation is that you kind of go back and revisit that. Okay. Clinical presentation, again, is acute or chronic. And you can see from here, Acute is asymptomatic. If it's symptomatic, it's going to cause fatigue, fever, body ache. So this is like a general response, infection, that something is happening to me. I'm not normal. I'm sick. So that kind of a feeling, but it's difficult. How many a time they're going to associate your condition with parasite? Very rarely. The problem with this particular parasite, and you must have realized that I picked up 4 or 5 different prototype parasites, and each of them are unique in causing some of the symptoms. For example, this particular parasite, Chagas disease, has an ability to cause cardiac symptoms. I did never mention so far. So far, I've been talking about abscesses. I've been talking about what you call intestinal and extra-intestinal. But in this case, you can imagine that this may cause arrhythmias. It's going to get heart failure and sudden death. So you wonder how would a parasite cause that, but it does. And for intestinal, it also causes megacolon, and he has megaesophagus. So what you need to understand in this case is that these organs have a standard size, but with continuous infection, chronicity, and things keep on changing. And sometimes it's like swelling. Sometimes it's what you call the thinness in the wall. So they keep on bloating up and up and up till you form a mega organ, right? And that could be taken as a what you call a mass, or we call space occupying lesion, SOL, and can be confused with cancer. How do you diagnose Chagas disease? We do a blood smear, thick and thin smears, and again, clinical findings and clinical likelihoods are there. We have serological tests if we want to find out if you really are carrying Chagas disease. As far as treatment is concerned, since I said cardiac is important, you want to make sure that depending upon which type of arrhythmia you have, which type of heart block you have, what kind of heart failure you have to treat accordingly, because there's a different set of drugs altogether on top of using anti-parasitic agents, which are patient-specific, right? But as far as the agents are concerned, so you can see from here, they are FDA-approved treatments, and they are 2 important. We have nifurtimox and benzimidazole. So nidazole, you can see many of them like metronidazole. Nidazole is like a special group, which probably they will teach you in pharmacy, is very important in terms of treating parasite. And I think, if I remember, I gave an assignment to somebody. I said that next time when you go to Sears or any store, you want to grab bananas, look at that big carton that they have coming from wherever. So on the side, you will see, and it said thiobendazole treated. It will say thiobendazole treated. So most of the fruits that are there in the market we tend to buy are treated with anti-parasitic agents. The argument in that case is that your bananas have that. So whether you like it or not, that's again, I'm not going to go into discussion about organic and non-organic stuff, but that's a fact that the way we are living without us knowing it, we are consuming antibiotics, we are consuming steroids, we are consuming, estrogen, so to speak, in the plastics. We are consuming anti-parasitic agent. And next time, if you go and let me know, you can take a photograph and send it to me. Thiobendazole. So thiobendazole, and why do you do that? Because the parasite kills the bananas. They're not worried about you; they're worried about bananas. But there you go. Okay. So next one is toxoplasmosis. Again, all these oses and it makes your life easy. Toxoplasmosis is causative in Toxoplasma gondii, and there are multiple methods of transmission. By far, I think you must have realized that we've been talking about water, and talking about what do you call foodborne diseases. So Toxoplasma gondii, the transmission again is via food. It's vertical transmission to mother to child, but we just add one more aspect to it, which is zoonotic aspect. In this case, those of us who are fond or who have pets like cats are more prone to this particular. That's why you have to have insurance for your pets and make sure that they don't carry and they don't transmit that to you. But nevertheless, if you're exposed to a situation and you're unaware of it, most likely, so we have at least 22.5% US kind of transmission of this particular toxoplasmosis. And in some other countries, of course, where they can keep pets without having any license or getting any medical coverage for that, they may be 95%. So it's a good job the government regulating people are doing. They want to make it mandatory on you to have your pets, but at the same time make sure that they're properly taken care of. This is also considered as neglected parasitic infection. So this is the term that they're using because it was put aside, you know, who cares? Because we care according to the incidence. If for some reason Zika virus was there, but it was not so obvious. So all of a sudden you see newborn baby with microcephaly, small heads, very common in Latin America, you start noticing and then panic creates. So that's important for us, that this is neglected parasitic infection. Again, very interesting life cycle. And in this case, particularly, what I want you to do now, again, is other than what I've so far explained to you, but you can see over here that now we have two different, normally when we have one, so they assume it's going to be same for male and female, right? That's number one for life cycle. When you have both male and female, it also takes into account that the transmission can be sexual as well, okay? The other important thing is that you can see if the more kind of vectors we add, the more problems we get. And especially for this case, as I said, cats are to be blamed because they can carry cysts, and then they can pass it to the human, but they can also pass it in the atmosphere. If in the homes, for example, if there are rats, if there are birds on farms, and then again, rats plus pigs plus sheep, so all farming, so more of a farming thing or more of the pet-like thing. If you happen to have that and you are not taking care of the excreta of the feline or here for cats, so it's going to contaminate the whole system and you will be exposed. Not only that, and if you, because a lot of food for you is coming from the farms. So some of the foods which are coming up from the farm, I gave you the example of the bananas, thiobendazole. You want to make sure that you don't carry all this stuff, right? You treat it. Now, you can see all of your luxurious exotic or non-exotic food is there, and water bodies are there, so you tend to handle. You know, people like handling. So that gives you this particular microorganism, toxoplasma. And then again, it becomes very complicated because where are you going to draw a line? What is it that you take care of, right? And you can also see there's another for the blood transfusion as well. There's another issue added over here. So there's a blood transfusion over here as well. Again, effective diagnostic. So you can also, you know, get that. So some of the diseases, especially 22.5% incidence is quite high. And 95 is very high for those people who are there. And normally, many physicians even are not trained because they did never see. I just picked up, like, I would say, at the most 20 bacteria or maybe 30 bacteria to teach you. Doesn't mean that they are only 30, but that's a minimum that we say, okay, at least you know. But for parasites, we are, not that they are neglecting, I'm neglecting, the way the course is designed is neglecting, we just have 3 lectures. And we trying to cover and give you the major and prototype things that are there, okay? But I'm pretty sure that you understand the problem in this case, for example, if you pay attention that, this is a tissue cyst. So the cyst that goes over there goes into the tissue. So this means it can go into the meat of these animals, if let alone that you don't care to take care of these things, but you do consume meat from these. So that is added to that because it goes into the tissue. And then again, you can see from here, it's consumed. The problem with this one over here is that, you can see pregnant women, that she can pass it on to her baby. So there's a vertical transmission as well. So that's a scary part in terms of how we deal. Now, problem for clinical asymptomatic. If you're immunocompromised, you may be symptomatic and you can have all those constitutional symptoms that, hey, I'm sick. If you are pregnant and you're infected with this toxoplasma, either you have a miscarriage or stillbirth. That again is a big problem that we normally see. How do you diagnose? So we look for, we do a MRI and CAT scan and find multiple lesions. Yeah, it should be the typo there. And then again, we can test for serological tests for IgM and IgG, and we take a tissue out and look for these particular parasites over there, Toxoplasma gondii. What can you do? How can you treat? And that's a problem there. If the person in the farms are asymptomatic, right, and they're passing it on to the animals being raised, and people having pets, and people not taking care of pets' excreta, and it's all over the place. So there are cysts everywhere, and so that's why it is considered as neglected, right? And it's on the back burner, we don't really know. So once you have symptomatic and seek attention, then we can do something. So first line is pyrimethamine, and you can add sulfadiazine to that, plus folinic acid. You can also we do secondary prophylaxis, especially for HIV patients, because they are prone to that. And I think I'll stop here. I'll take trichomoniasis next time, and that will conclude the lecture series for parasite.